The final area that I'd like to describe for you in complications are hard breasts. Well, do the implants go hard? Of course they don't. They're immutable. Implants are inorganic. They're not organic. They're not human. They're not living. They don't change. The body's response to a foreign body is to form a scar around it. If that scar is thin and fine, then you've got soft, jiggly breasts that do everything you want them to do. If that scar is thick as shoe leather and very hard, then you've got two tennis balls on your chest. Well, how do we deal with this? Now, the old way of dealing with it, which never worked in my opinion, was the breast massaging, moving them up, moving them down, moving them around, laying on the floor and rolling on your breasts. That's a mechanical approach to a biochemical problem, and it won't work. I did a little study when I was at Stanford, and I looked at the women who had breast implants that went hard. Half of them did massaging, half of them didn't. Half of the ones that did massaging got hard, half of the ones that didn't do massaging got hard. So I concluded massaging makes no difference. So what does make a difference? Dealing with the problem. And the problem, you've got some etiologies. In other words, what leads to hard breast? And then you've got to deal with the hard breast. Okay, the two areas, the two things that we know about hard breasts are one, capsular, or hard breasts are capsular contracture. The first area is blood around the implant. You do not want blood around the implant because it'll lead to a hard breast. The body converts that blood into thick collagen, and then you've got a hard breast. How do you get rid of that? One, you do a very neat surgery. Two, you wash out any blood that may be in there. Three, you do it endoscopically so you can see every little bleeder and stop it. Four, you put a drain in to drain out whatever excess or minimal bleeding there is so you get a very dry field. And five, of course, as I mentioned before, you have the patient take it easy for the first 3 days. Decrease blood around breast, much less chance of hard breast. The next thing, and this is very well studied and very well described by lots of authors, is bacteria around the breast, but not the pathogenic bacteria that will cause pus and an infection, but non-pathogenic bacteria. Human beings live with bacteria on our skin all the time. It's called staph epidermidis and strep coagulase negative. It's not the kind of bacteria that leads to an infection, but once it gets inside, your body reads it as a foreign body, an invader, and it attacks it by putting out by putting out an immunoglobulin to create more collagen to wall off the bad invader, which is the non-pathogenic bacteria. How do we get that inside of us that sets off this problem? And the answer is, if you've ever seen a doctor try to force an implant into a pocket, I've done it too many times. You push, 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 you're dragging all the bacteria off the skin. That then gets inside, and for the patient that's going to respond to that, you end up with a hard breast. Dr. Keller, and I usually don't advertise anybody, but this was brilliant. Dr. Keller invented a funnel, and it looks like something Julia Childs would decorate the top of a cake with. And if you drop the implant into that funnel, now it drops sterilely from a sterile box into a funnel, that then goes directly into the pocket and then directly underneath the pectoralis muscle, and you never touch it. It's a no-touch technique. The Keller funnel plus drains plus endoscopy leads to very soft breasts in well over 90% of all patients. But what if the patient, no matter what you do, is going to get a hard breast anyway? Then the next thing is accolate. I'm going to use a lot of big words now, but accolate is an asthma pill, and it's been around for over 20 years. And accolate, and its generic name is Zifferlucast. If you take a pill, it modulates the immune system. It kind of dampens it down, and this leads to softer breasts. It obviously leads to less asthma. Accolade has a sister drug out there known as Singulair, which you've probably seen advertised on TV. So Accolade will give you softer breasts. And the way it does it, it decreases the amount of new collagen going into the scar around an implant. If that scar, again, is thin and fine, your breast will be soft and look wonderful. So by decreasing the new collagen going in, but not affecting the old collagen going out, you get a softer breast. So to go back and talk about the capsular contracture. Capsular contracture occurs when the body's response to your implant is augmented by something like blood around the implant or bacteria around the implant. Okay, so that's the surgery. I, in my practice, give Accolade or Ziffer-Lucas for 90 days before you get a problem, hoping to get you into a steady state where your breasts stay nice and soft. Does it work every time? Yeah, most of the times it does. Every once in a while we need to come up with some ancillary treatments. But this is basically a kind of a simple way of getting soft breasts, is take Accolade right at the time of surgery. Breast ptosis or droop. How do you deal with breast ptosis? Well, first of all, if it's first-degree ptosis or xerotosis, or xerotosis is also known as pseudotosis, you can use a larger implant and it will lift the breast up. So that's one technique. If the breast is a first-degree ptosis or early second-degree ptosis or droop, then you can use an implant plus dual plane. And dual plane is meaning you go in two planes. The first plane is below the muscle, and that's where the implant goes. The second plane is above the muscle, and you just go in through the same incision in the armpit, release above the muscle, and now the nipple is allowed to move upward. So it allows the nipple to come upward, the implant goes downward, and the combination of these two moves gets rid of basically first-degree ptosis for sure, and even some second-degree ptosis, early, beginning second-degree ptosis. Well, what if the nipple is too low and you're not able to do it just with a dual plane? My next favorite way to do it is the Benelli mastopexy. B-E-N-E-L-L-I. Louis Benelli is a plastic surgeon from Paris. I lectured with him for about 12 years on the mainland, and I actually won a prize for the best videotape in plastic surgery. So if you Google my name, Schlesinger, and Benelli mastopexy, you can view my video, and that'll tell you exactly how the surgery is done. But basically, skin is taken out around the areola. The areola is moved up, never taken off the body, just moved up. And then you put a permanent suture around the areola and pull up, and it lifts the breast and it lifts the nipple. So it's called a purse string suture. And that's the Benelli mastopexy. Great operation for a very specific problem of a little bit of droop, not a lot of droop. The next stage is the standard mastopexy, and there you get a scar around the areola, a vertical scar and a horizontal scar. And for people with really droopy breasts, that's the only answer. There are a couple other operations out there which I've tried, and I don't feel they're very valuable. I don't believe in the vertical mastopexy. It usually puts the nipple too high, and it also sometimes has breast tissue hanging down below the bottom of the breast.